In this section, we are going to discuss the treatment of asthma. The structural changes that happen in asthma can be explained using these two diagrams. You see, the first diagram shows the airways before asthma, whereas the second one is after asthma. In the first one, the structure is somewhat smooth. In the first diagram, the lining of the membranes, the outer linings, are smooth. The second one, you can see swelling. The fibers look like that they have gone in between and there are swelled up portions. Actually, the muscles have undergone contraction and the mucus has come up in the tube and there is swelling. In most people, asthma has two phases, bronchospasm, and bronchospasm is nothing but sudden narrowing of the bronchioles. It's narrowing of the bronchioles, whereas inflammation is swelling up of the walls of the tubes. So you see, the first phase or the early phase is bronchospasm. Here the narrowing has occurred, and then the inflammation, the mucus has come and other things, other mediators have been released and the tissue has swelled up and the appearance have changed. There is constriction of the. This is ear inflammation. Now let's go to the treatment. We know there are two types of. The human respiratory system is under involuntary control. ANS has got two components, sympathetic and parasympathetic. The sympathetic component is responsible for relaxation and parasympathetic component is for constriction. We know sympathetic stimulation is mediated by beta receptors and parasympathetic stimulation by cholinergic receptors. So, to stimulate the sympathetic fibers, we have beta agonist. To stop the stimulation of cholinergic fibers, we have got anticholinergics. Because if cholinergic is stimulated, there will be constriction. We need to stop the constriction. So, we'll be blocking the possibility of their constriction. And the group of drugs that can do this is anticholinergic. We have two types of beta agonists, short-acting and long-acting. In the short-acting category, you have got the classic drug salbutamol, albuterol, and there is tarbutaline, bambuterol, and other drugs like that. The number of drugs in these groups are many. In the long-acting category, we do not have many drugs. And we have got the salmeterol, formoterol, etc. Short-acting category starts acting almost immediately, within 3 to 5 minutes. And the duration of action is not very long, 4 to 5 hours. The salmeterol, on the other hand, goes long time and the action can be prolonged up to 12 hours. And these are used mainly for maintenance. So, once again, the short-acting categories are quick-acting and they are used as rescue medicine. So, the anticholinergic drugs prevents constriction. So, drugs in this class are atropine, diphenhydramine, ipratropium bromide, etc. These drugs actually block the muscarinic receptors. And you know, of the two receptors, muscarinic and nicotinic receptors, muscarinics are slow-acting receptors. So because they are slow-acting, they are not as fast as the beta agonist. And their side effects are also much less. They can be used safely in the elderly people. Beta agonists are invaluable as rescue medicines because when somebody is from a flare-up, gasping for air, the first need is to relieve the symptoms, to restore the air supply. But there are serious side effects also. The beta agonists, they cannot go with the beta 2 receptors. So in some cases, the chance of contraindications, beta agonists can increase the heart rate. They can cause skeletal muscle cramping also. Whereas anticholinergics, they are slow acting, but they do not have serious side effects. So most of the times anticholinergics and beta agonists are given together. One as rescue medicine, another to prevent further damage, that is constriction, as a maintenance therapy. Beta agonists usually relax the smaller tubes, and anticholinergics have got an added advantage. They work on both small and big tubes. One very important group of medicines in treatment of asthma are steroids. Steroids have got anti-inflammatory effect. And often we see people taking a short course of steroids, and that gives protection. So in a way, it prevents against your inflammation. But steroids have got side effects. But now we have got metered dose inhaler, and the side effects are reduced, because in metered dose inhaler you have got the doses in microgram levels, whereas in tablets and conventional dosage forms the doses are in milligram levels. Yet the oral thrush, a fungal infection, is common in asthma, and rinsing of mouth after each puff is recommended. Another important group of medicines used in the treatment of asthma is methylxanthine. Drugs in this group are quite common. Caffeine, theobromine, theophylline. These are the drugs that are used in the treatment of asthma. Of this, theophylline used to be very popular once. It has got unique properties. It's a direct bronchodilator, immunomodulator, and anti-inflammatory. All three components of asthma, that is bronchoconstriction and exaggerated immune response or hyperresponsiveness and inflammation, can be counteracted by theophylline. But it has got a problem. The therapeutic window is quite small. So the dose of theophylline should be monitored. And sometimes theophylline is given at a low dose. This at lower concentration, the bronchodilator effect is rather big, but the other two effects like immunomodulator and anti-inflammatory action is there. If the concentration of theophylline goes above the therapeutic level, there can be very serious side effects. Another drug I forgot to mention is cromolyn sodium. It's a mast cell stabilizer, and mast cell releases histamine that causes inflammation. So now we are coming to the modern drugs of asthma. In this group we have got leukotriene receptor antagonists. Leukotrienes are mediators of inflammation, and blocking their receptors will prevent against inflammation. So they are used in maintenance therapy, and they have got far lesser side effects, can work on both the components, that is bronchoconstriction and inflammation, and drugs in this group of montelukast, zafirlukast. So we know for asthma, the number of drugs are too many, because the process of asthma is related to immunomodulation, inflammation, and bronchoconstriction. So you can cut off the, and too many channels are there involved in the process of asthma. So intervention in any of the channels can be beneficial for controlling the asthma. So the good news is, though the disease is incurable, the asthmatic has to carry the disease Though the disease is incurable, with modern medicines they can live a normal